Chronic and persistent diarrhea. So any diarrhea which is persistent for more than 2 weeks is considered as persistent diarrhea, and any diarrhea more than 4 weeks is considered as chronic diarrhea. So we'll go for the case-based scenarios. So a 40-year-old female who underwent cholecystectomy developed the watery diarrhea more than 10 times a day for the last 3 weeks. So she developed diarrhea after cholecystectomy for that is more than for last 3 weeks. That is a case of persistent diarrhea. It's a watery diarrhea. So any patient any person who is elderly or unexplained anemia is there, unexplained constipation is there, unexplained bloody diarrhea is there, unexplained weight loss is there. So in all of these cases, these are mostly a red flag signs to undergo a colonoscopy and to look for any malignancy is present or not. Here it is a watery diarrhea. So this is mostly a 40-year-old female. She is not elderly also. She underwent cholecystectomy. What might be the cause of diarrhea? One thing, because of the antibiotics what we are giving like ampicillin or anything, so that might be a possibility, that might be a cause of diarrhea. So always any drug related cause like any antibiotics, if they are being taken, you need to look for them. So that might be ruled out. So and also next thing you need to rule out is any osmotic laxatives, like any patient taking magnesium supplementation or any lactulose syrup or any PEG. So they might be taking after post-op, there might be post-op ileus. So some people might be taking post-op laxative for long time. So if there are anything that like that, so they need to be ruled out also. So first any antibiotics or any drug related history that is taking any laxatives, you need to rule out them. So if they are all ruled out, so after cholecystectomy, the bile acid is directly secreted into the intestine. So that might be malabsorbed, and so because of excessive bile acid that is coming into the intestine, that might be not be absorbed, that might cause the bile acid related diarrhea. So this might be a case of bile acid related diarrhea, and most of the bile acid absorption occurs in the terminal ileum, terminal part of the small intestine. So this might be a case of bile acid related diarrhea. So this might be relieved after I add cholestyramine something. So this might be a case of bile acid diarrhea. So I'll give you one more case, a case of Crohn's having the terminal ileal ulcers and all, presenting with chronic diarrhea. So that might be related to Crohn's also. Sometimes because of terminal ileal ulcers, that might be due to Crohn's, or that might be due to some systemic infection that is having ulcers in the terminal ileum and terminal small intestine. So because of the terminal ileum ulcers and ulcers in the ulcers and all, so bile acids won't be absorbed, so they will have bile acid diarrhea. So any ulcers or any like in the TB, Crohn's, anywhere where the ileal ulcers are there, where bile acids can't be absorbed, they can also cause bile acid diarrhea. So in that case also you can try cholestyramine. So this is a case, interesting case, where you can find bile acid related diarrhea. So bile acid diarrhea can be seen any case when you underwent cholecystectomy or any terminal ileal resection is done, or any patient having terminal ileal ulcers in the TB or Crohn's, or any chronic steroid usage or anything where they have ulcers something. Steroids also can cause ulcers in the small intestine. So any of these patients will have bile acid malabsorption, they can cause bile acid related diarrhea. A 65-year-old female, known case of GARD and PPA using SSRI for her depression, now present with complaints of profuse watery diarrhea. So what might be the cause? So first thing is, she is a known case of GARD. So this is reflex disease for which she is using PPA. So because of the proton pump inhibitors, there is some amount of decrease in acid production in the stomach. So that itself prones the patient for the infection in the small intestine or colon or anywhere in the GA. Because of one of the protective mechanisms of the GA infection is the HCl in the stomach. So stomach acidity is one of the protective barriers. So that is lost. So there might be a case of infection in the stomach. That is one more cause. So patient is using SSRIs for depression. So selective serotonin receptor inhibitors is uptake inhibitors she is using, depression for which she is using. So sometimes serotonin reuptake can also cause diarrhea. So that might be a cause. So one thing, the patient might have infection, or something drug related diarrhea can also be a possibility. So any infections you need to look for. So sometimes small intestinal bacterial overgrowth can be seen because of the loss of gastric acidity. So small intestine bacterial overgrowth can be a possibility. How do you direct the small intestine bacterial overgrowth? One thing you can do, you can do this duodenal aspirate and look for culture. Anything more than 10 power 5 cultures, it is suggested small intestinal bacterial overgrowth. So you give rifaximin, so they will resolve, most of them. So then what else can you do? The one thing you can do small intestinal bacterial overgrowth is you can do hydrogen breath test. You can do hydrogen breath test where you give lactulose. So generally the spike is seen after the 2 to 4 hours. Like any breath, more than 20 ppm spike will be there. That is because of the fermentation of the sugars which are not absorbed in the colon. So which are not absorbed in the small intestine, they are generally fermented in the colon. So they release the hydrogen. So that is generally seen in 2 to 4 hours, generally spike. So if it occurs before 90 minutes, that is 180 minutes only it is occurring. So that is suggests a fermentation is happening in the the small intestine itself. So the peak will occur more than 20 ppm spike will ppm hydrogen breath test you occur in the breath analyzer, you will spike the you'll find the peak within less than 90 minutes. That is suggest a small bacteria are present in the small intestine. So that is the small intestine bacteria. That is one more test you can do. So the treatment of choice is rifaximin. So that is the two possibilities. One, GERD related small intestine growth made with it, that can be diagnosed by duodenal aspirate. Sometimes it can be diagnosed by breath and hydrogen breath test also, where you give lactulose and lactate and lactose and check for the hydrogen breaths within 90 minutes. 20 ppm will be there. So then what is the other causes? The GERD, she using PPA small SSRI. She is 65-year-old female. So one of the other causes, these both are negative. Let's say you give rifaximin therapy, that is not there. You remove drugs also, but still the patient is completely not recovered from the watery diarrhea. So you underwent colonoscopy. You did colonoscopy to look for any organ deficiencies in elderly. You did the colonoscopy. You found microscopic colitis. So, and in that microscopy, small collagenous bands are there. So that is suggest of collagenous colitis. So generally two types of microscopic colitis is there. One is collagenous, the other is lymphocytic colitis. So both are microscopic colitis. So if the lymphocytic colitis, you find predominant lymphocyte, collagenous colitis, you find collagen predominant. So based on the differentiation, the both are microscopic colitis. So the risk factors having microscopic colitis is any elderly female who is using SSRIs or PPIs or any statin therapy. So these are all NSAIDs. These four are risk factor for the microscopic colitis. Why is microscopic colitis? These four drugs, whatever statins, NSAIDs and PPIs and SSRIs, they damage the epithelium and intestinal epithelium, that causes microscopic colitis. So this might be a case of if the patient is not having any SIBO or any drug-related diarrhea, the most common cause is microscopic colitis. You avoid the offending drug, so mostly they'll recover from the whatever microscopic colitis is there. So what are the histopathology will tell us whether it's collagenous or lymphocytic colitis. So these are the risk factors. Main drugs you need to be SSRIs, PPIs, and male is developing bloating and pain abdomen and mild diarrhea after consuming curd and milk. So these are curd and milk contain high amount of lactose. So any patient having lactase deficiency will develop such symptoms. So general lactase or some disaccharidases will be there. So deficiencies will cause such symptoms. Most common thing is lactase deficiency. So generally avoid any lactose containing foods. Generally they will recover from that. So this might be a case of lactase deficiency. That is very common in adult. So ask for any milk diet related diarrhea or something. Any milk, especially milk products if they are consuming, if they have some diarrhea related to milk products or something. So generally avoid such drugs, then they'll any such foods, so they will recover. A 40-year-old female recently traveled to India from US, developed watery diarrhea, pain abdomen, nocturia, and has on lab reports low vitamin D, B12 and folate. So she's recently traveled to India. So after that she developed watery diarrhea, pain abdomen, nocturia. So she's having diarrhea and pain abdomen. What is the nocturia? So nocturia is suggestive of malabsorption. So generally if the water, whatever you consume in the afternoon and evening, they're slowly absorbed from the body. So because of the malabsorption, they're slowly absorbed from the body. So that they'll cause, because of the excess water which is present, they should need to be exceeded in the urine. So that nocturia will be there. Because of the delayed absorption, nocturia is there. So and as also low reports show vitamin D. So there is definitely vitamin D, B12 and folate. So vitamin D is generally absorbed in the proximal small intestine. B12, magnesium and bile acids are the one which is absorbed in the distal part of the small intestine. B12, bile acids and magnesium. These are three are absorbed in the distal part of the small intestine. So they have vitamin D deficiency. Definitely deficiency is there, and also some diarrheal symptoms. So she's recently traveled from India. So first, anyways, any patient traveling from the tropical country, you should always look for any infection cause. So this might be a case of tropical sprue, because they recent travel to any South Asian countries or African countries, and who are especially Western people developing watery diarrhea, and also is having some two or other malabsorption. Generally you diagnose tropical sprue. Generally it is very similar in generally you don't have any diagnostic tests, and you generally go for the intestinal biopsy, you go for small bowel duodenal biopsy. So you find similar picture to the celiac, whatever celiac, say villus atrophy is there, cryptic hyperplasia is there. Generally villus atrophy is not significant as compared to celiac sprue, but just some mild villus atrophy will be there. And also what is the difference between celiac and tropical sprue is tropical sprue involves entire small intestine. It's like from duodenum to entire terminal, it involves same pattern, like entire small intestine is involved equally. Whereas you take the celiac predominantly involves duodenum and proximal part of small intestine. When you go distally, celiac doesn't affect the distal part of small intestine, but so that differential involvements, like tropical sprue involves all the small intestine equally, whereas celiac predominantly involves proximal small intestine. That is the difference. And one more thing, tropical sprue villus atrophy is not significant, and also mononuclear infiltrates is more significant, whereas in celiac you will find lymphocyte involvement more. So that is the difference. One is similar involvement in the entire small intestine, which is seen in tropical sprue, whereas the lymphocyte predominant is seen in celiac, whereas in the tropical sprue you find more of mononuclear, and also villus atrophy is significant in the case of celiac. So this might be a case of tropical sprue. You give tetracycline for at least 4 to 6 weeks, then patient might mostly recover. So what if the patient has persistent diarrhea after you treat with tropical sprue also? Sometimes what happens is after post-infectious, after long infection or something, they'll develop like irritable bowel syndrome is a possibility. So that is a possibility. They have persistent, you should look at irritable bowel. We'll discuss about what is irritable bowel syndrome in the next cases. But if the persistent after that also, irritable bowel syndrome is a possibility. A 30-year-old female, known case of Crohn's disease, underwent ileal resection, now developed watery diarrhea associated with low albumin, low B12 deficiency, and also recurrent pain in the right hypochondrium. She is a 30-year female. Because of the Crohn's disease, she underwent ileal resection. So she has watery diarrhea now. So one thing, because of the ileal resection, she has loss of B12, magnesium, and bile acid. So because of the bile acid malabsorption related diarrhea is one possibility. So for that you give cholestyramine. So because of the ileal resection is there, so this patient might have short bowel syndrome. So what is short bowel syndrome? Generally anything less than 200 centimeters of small intestine is considered short bowel syndrome. So this might have, because of the ileal resection, short bowel syndrome is a possibility. So they'll have multiple deficiencies because amount of carbohydrate malabsorption will be there, protein malabsorption will be there, vitamin malabsorption will be there because of the decrease in the small intestine. Because small intestine is the predominant side where you where the intestine absorbs most of the nutrients. So because of the malabsorption there will be diarrhea. So this because of that, because there is small intestinal rejection, this is a short bowel syndrome, anything less than 200 centimeters. So because of the malabsorption, the patient will develop diarrhea. So this is like a short bowel syndrome. Maybe associated bile acid diarrhea is also there. So short bowel syndrome is a possibility. You supplement any vitamin A, D, E, K. You supplement vitamin supplementation, and also recurrent pain in the hypochondrium is mostly because of the calcium stones. Because of the gallbladder stasis, they develop the gallstones. That is because of the right hypochondrium pain is because of the gallstones. Majorly calcium stones are the one which develop. So that might be the cause. There are a lot of renal stones also because of the oxalate. So you generally give a vitamin supplementation. You generally advise medium chain fatty acid because long chain fatty acids might not be able. Both long chain fatty acids require intestine and also micelle formation for the absorption. Medium chain fatty acid doesn't require micelle formation much. So generally medium chain fatty acids are preferred in them. So you advise medium chain fatty acid, vitamin supplementation, other nutrient supplementation you advise, and also for water, any bile acid diarrhea you advise cholestyramine also. So this might be a case of short bowel syndrome. We'll discuss about short bowel syndrome, but this might be a case of short bowel syndrome. A 40-year-old female, known case of scleroderma, using PPI for GI, presented now with emergency in delirium and asking yesterday he had a complaint of steatorrhea and also low albumin and anemia and poorly built. So she is a case of scleroderma. The patient is having scleroderma and she is using PPI for GID. So she is having proton pump inhibitors also. Now she developed in delirium. She has malabsorption, she has fat malabsorption, she has protein malabsorption, she has anemia also. There is definitely malabsorption. What might be the cause of this case? So this might be a case of one thing. She is using PPI. There is decreased there is decreased acid production. She is having scleroderma. There is gut motility is also decreased. Because of the decrease in the gut motility, what will happen is there is a migration of gut bacteria from colon to small intestine. So this might be a case of small intestinal bacterial overgrowth, like I told you before. So because of the PPI and also because of the decreased gut motility, there is a migration of gut bacteria. So that might be a cause, small intestinal bacterial that is causing malabsorption, steatorrhea and all, and low albumin. They are all cause of that. So small intestinal bacterial overgrowth is generally treated with rifaximin. Rifaximin is the drug we use. So SIBO is the one. So SIBO can occur in a number of causes. Because of the use of PPIs. The other is because of anything that decreases the gut motility. That might be hypothyroidism. That might be scleroderma. Sometimes some people have slow colonic transit time. And also any patient who underwent iliac surgery where the ileocecal wall is removed. So because of the removal of ileocecal wall, there is migration of gut bacteria. So any patient who underwent ileal surgery also. So these people are at risk. So these are all at risk of small intestinal bacterial overgrowth. So in them you should give rifaximin as a drug of choice. A 28-year-old doctor has complained of recurrent abdominal pain 2 times per week and pain relieved on defecation and frequent change in bowel habits of having watery diarrhea and constipation. So she is a 28-year-old doctor and she is having recurrent pain abdomen. Like she is complaining of once or twice a week. She is complaining recurrent pain abdomen, which is relieved on when she went to she's defecation. She is relieving the pain abdomen is relieved on a defecation, and there is a frequent change. She is having on and off diarrhea. She is having constipation. This is classically a case of irritable bowel syndrome. So irritable bowel syndrome, what will happen? They like on and off constipation, on and off diarrhea. It can help pure constipation. It can help pure diarrhea also. But the classical symptom is that they'll have pain abdomen, but on defecation the pain will relieve. and also they won't have any nocturnal symptoms. Generally they don't have any nocturnal symptoms. So only morning time symptoms will be there, pain will be there, and defecation pain will be relieved. They might have completely only diarrhea or completely constipation, but most common is mixed diarrhea and constipation. So sometimes they'll have diarrhea, sometimes they'll have constipation. So generally it will be lasting for more than 3 months. That is the classical history of irritable bowel syndrome. It might be related to some psychiatric disorder like any depression or anxiety, mostly anxiety related. Sometimes post-infectious IBS is also a possibility. So this is mostly because of the visceral hypersensitivity. So gut hypersensitivity is the most common, and also serotonin metabolism problem. So that is the case of irritable bowel syndrome. How do you manage irritable bowel syndrome? Based on the constipation and diarrhea symptoms you manage. So generally for diarrhea, what you give? You give any, you can try cholestyramine, you can try loperamide. So any small dose of opioid can you try. So sometimes you can give ondansetrons also. So these are the drugs you can give for irritable bowel syndrome, diarrhea. For irritable bowel syndrome, any constipation related syndrome, you give high fiber diet. So you give high fiber diet. You can also give this prokinetic drugs, and also you can give chloride channel agonist, which increases the chloride secretion into the gut. So you can try all this. I'll discuss about the drug parts later, but these are the various options. But you need to remember the classical history of irritable bowel syndrome, where they'll have pain abdomen, which is relieved on defecation. They are on and off symptoms of constipation and diarrhea, especially when they are stressed out. They'll have more of these symptoms, and also they won't have any nocturnal symptoms. Generally, they won't have any nocturnal symptoms. Only morning time symptoms will be there. So that is a classical syndrome. Generally, they'll last for more than. They have other functional disorder, any anxiety, something or the other, post-infectious is also a possibility. A 48-year-old male presented with watery diarrhea, joint pains, and has tachycardia associated with fever, and has recent onset depression and psychotic attacks. What is this case? So she is a 48-year-old male. He has watery diarrhea. He has joint pains also. He has tachycardia also, and has some CNS manifestations also. So any patient who is having watery diarrhea associated with joint pain, some CNS manifestation and cardiac manifestation, you should always look for Whipple's disease. So Whipple's disease is the one which has more like joint pains, cardiac manifestation, and any CNS psychiatric manifestation with a long term have memory problems also. So cardiac can have myocarditis or pericarditis or endocarditis also sometimes. So this is a case of Whipple's disease, where you give biopsies, you have pass positive macrophages will be there. The closest diagnosis for this is Whipple's disease, Mycobacterium aviale complex. MAC bacteria also will have similar pictures, but histopathologically you can differentiate. How to differentiate, you read about it. But any 48-year-old male having watery diarrhea, is having diarrhea, joint pains, cardiac manifestation in the case of tachycardia, any myocarditis or pericarditis is there, and CNS manifest like any psychiatric manifestation or something, you should always suspect Whipple's disease. So Whipple's disease is a possibility. You go intestinal biopsy, you'll find pass positive macrophages will be there. So histopathologically you read about how to differentiate between the Whipple's disease and Mycobacterium aviale complex. They are very close differentials. So this is a classical case of Whipple's disease. They have joint manifestation, cardiac and CNS manifestations. A 40-year-old woman who is from Delhi developed chronic watery diarrhea, has bone pains, and has mild transaminases, and USG showed reduced splenic size. So she is from Delhi. Most of the Delhi people will, because of based on the North Indian people mostly eat wheat related things. So wheat is the most common there, because wheat is more good. We eat more of rice. So she developed chronic watery diarrhea. She has bone pains and also mild transaminitis there. So you should always ask for dietary history. So she is mostly consuming wheat. So first thing you should always, most common cause of any chronic diarrhea is celiac in our India, especially in North India. The other thing are lactase deficiency and bile acid diarrhea is very common. So these are three are very common. So in this case, because North Indian Delhi bony pains suggest of some vitamin D malabsorption or calcium malabsorption. They are classical iron deficiency, calcium deficiency, and vitamin D deficiency, because proximal intestine is more common involved. Celiac has predominantly proximal small intestine, where tropical spleen involves entire small intestine. Some people will have other associated mild transaminated. Sometimes cryptogenic cirrhosis is also possibility. So they have mild transaminasis also. Celiac is also associated with other autoimmune condition like hypothyroidism or type 1 diabetes. So this is a classical case of celiac disease. First you advise gluten foods. What are gluten foods? Any wheat, rye, and also any bread, pasta. These all have wheat, bread, pasta. These are all made of wheat only. So you need to avoid all this. Main wheat, rye, barley. These are all contains like gluten. So oats generally they say, but pure oats are generally doesn't have any gluten. So pure oats doesn't generally contain any gluten. So these are the things you need to avoid. Mainly wheat, rye, and barley. These are the things you need to avoid. So you can advise rice, quinoa you can take. So these are all the things you can take. So this might be a case of celiac disease. You can, how do you work up for you go for duodenal biopsy, where you go villus atrophy, cryptic hyperplasia will be there, and lymphocyte predominant will be there, where they grade on Marsh grading. You can use IgA anti-TTG, but the problem in celiac disease, most of them are IgA deficient. So in case of that, if the IgA TTG is negative, you should go for IgG anti-deaminated glycated protein, gliadin protein. So IgG anti-DGP also you should do. So if IgA anti-TTG is negative, you should do for IgG anti-DGP. So that might be positive. They have a strong predisposition to HLA DK2 and DQ8. So HLA DQ2 DQ8 will be mostly positive in this case. If both are negative, you go for HLA testing, if DQ2 DQ8 are negative, so then there is unlikely the patient has celiac disease, because they have negative predictive value more. So if DQ2 DQ8 are there, unlikely the patient has celiac disease. That is one possibility. This might be a case of celiac disease where they have transaminitis, water diarrhea, some multiple nutrient deficiencies will be there. You do IgA anti-TTG. If it is negative, mostly IgA deficiency is a possibility. You go for IgG anti-DGP. So, and also you give duodenal biopsy, where you find a villus atrophy, cryptic hyperplasia, lymphocyte predominance is there, where you give mask reading. Generally you go for gluten-free diet. So some patients, generally they tell classical cases of gluten, they have diarrhea with gluten diet, but they don't have any IgA anti-TTG or IgG anti-DGP, and biopsy is all normal. So that might be due to the gluten related only, but it might be non-celiac. So non-celiac gluten related diarrhea might be a possibility. So in that one also you advise gluten-free diet only, but that not is a celiac, that is not a celiac case. So but that is a gluten related diarrhea. So this is one more thing I want to tell you. This is a case of celiac disease. So what is the significance of reduced splenic size? So why is having hyposplenism in the case of celiac disease? So what is the cause of reduced splenic size in the hyposplenism? Any case of malabsorption, most common is celiac. So any case of malabsorption, there is a loss of lymphocytes. Predominantly CD3 plus lymphocytes are the one lost. So that is classically seen in the case of celiac disease, because of loss of lymphocytes. So splenic is is a secondary lymphocyte organ. So because of loss of lymphocyte, there is a atrophy of the spleen. Because of loss of lymphocyte, there is a atrophy of that is the reason for hyposplenism in the case of celiac disease. So there is a reticuloendothelial cell atrophy in the case of spleen. So that is a loss of because of loss of lymphocytes in the celiac disease. Because of any malabsorption, you have loss of lymphocytes. So because of the loss of lymphocyte, there is an atrophy in the spleen, because it is a lymphoid organ. So that is the cause of hyposplenism in the case of celiac disease. So one more thing, how do you differentiate, like patient is having total protein low and low albumin is there. So how do you differentiate whether it is a renal cause or cardiac cause or hepatic cause? So that is one more thing. That is one more thing I'll tell you. This is a clear statement from Harrison's. Generally, any intestinal malabsorption will have low protein, low globulin, low albumin. So generally in the case of hepatic and renal failure, they will only have low albumin. Generally the globulins will be normal, total protein will be generally in the lower limit of normal range. So generally in the intestinal malabsorption, you will find both low albumin and low globulins. So in other causes of renal failure, you will find mostly low albumin. Globulins will be generally normal. So that is how you differentiate. If you see both low albumin and low globulin, generally suspect intestinal cause. So in them both low albumin, low globulin, total protein also will be low. So in the case of renal cause, mostly low albumin will be there. In hepatic also, mostly low albumin will be there. In long-term cause, globulins will be low, because globulins are produced both by hepatic and other lymphocytes. So that is why there. If only low globulin is there, you should suspect any plasma cell disorder, any globulin deficiency you should suspect. In immunoglobulin deficiency. His 16-year-old boy complaining of diarrhea after eating oily food and relieved when he avoids food, and he has ataxia on examination, and peripheral smear showed acanthocytes, and total cholesterol is 90 milligrams per deciliter. So he's classically complaining of oily food diarrhea. When he's taking oily food, he's having diarrhea. When he avoids that food, he doesn't have any diarrhea. But he has ataxia on examination. When he examines peripheral, there is ataxia, not cerebellar. There is ataxia. And also peripheral smear showed acanthocytes. And total cholesterol is 90 milligram. So before interpreting this, what is the normal total cholesterol? Generally more than 200 is a normal total cholesterol. So 90 milligram is very low cholesterol. So patient is having low total cholesterol, acanthocytes are there, ataxia is there. So patient is, you can, by this you can tell there is some fat soluble vitamin deficiency, that vitamin E can cause ataxia, and peripheral smear showed acanthocytes. Acanthocytes is because of the membrane defects. Cholesterol forms the membrane of RBC, so that acanthocytes are there because cholesterol membrane defects. So you can tell from this there is fat soluble vitamin deficiency, and steatorrhea is fat deficiency is there. From history also you can say oily foods, there is steatorrhea is there. So classically there is fat malabsorption and fat soluble vitamin deficiency. So this 16-year-old male, their cholesterol is also low. This is a case of A beta lipoproteinemia. So because of the absorption of because of the ApoB protein deficiency, there is a MTP, sometimes MTP also is a deficient. So a beta lipoprotein is a deficiency because of intestinal malabsorption. The cholesterol won't be absorbed, triglyceride and cholesterol won't be absorbed, so there won't be any, there will be have low cholesterol, low ApoB levels, there won't be any cholesterol in the membranes also, their membrane defects will be there, attacks related, it will be symptoms will be there. This is the beta lipoproteinemia. How do you diagnose? After eating fat food, you go and biopsy the intestine, you will find fat loaded intestinal epithelial cells. So after 48 to 70 they clear off, but immediately after food, for next 24 to 48 you will find fat loaded intestinal epithelial cells. So that is how you diagnose. A 30-year-old male complaining of diarrhea, especially after eating apples or pancakes with maple syrup or ice cream. So this is one more thing you need to observe. There are something called FODMAP diets. They're fermentable monosaccharides and polyols. These diets have high fructose and high polyols. They're highly fermentable. So these can cause diarrhea. In the form of IBS, they can cause diarrhea. So FODMAPs can cause diarrhea in them. So this is a possibility. So FODMAP states is a possibility. FODMAP states are apple and apple, any fructose containing foods or any maple syrup containing food, ice creams are all FODMAP states. You avoid them. So low FODMAP diet, what is the low FODMAP diet? I'll again explain later. So you avoid FODMAP states, then generally they'll have recovery from the diarrhea. So these are the various case-based scenarios. I didn't discuss about Crohn's and ulcerative colitis. That is a whole different spectrum. Generally Crohn's can present as different. They can present with fistulas, they can present perianal abscess, they can present with strictures. So they can have wide differentiation. They wide different range of presentation. They can present overlap the ulcer also. And ulcerative colitis generally present bloody diarrhea. Most of the cases we discuss are watery diarrhea. So I'll discuss Crohn's and ulcerative colitis separately. Case-based scenarios, we will discuss about the various causes of chronic diarrhea. One is secretory. How do you describe the secretory and osmotic diarrhea based on the stool osmolar gap, where you measure the measured and calculated as stool osmolarity, and anything more than 50 is suggestive of osmotic diarrhea, anything less than 50 is suggestive of secretory diarrhea. So this is how you measure serum osmolarity, stool osmolarity, and how do you calculate. Read about it. I mentioned about in the acute diarrhea episode. Go back and look at it. So secretory diarrhea, most common cause are any stimulant laxatives or any ethanol injection. How ethanol injection generally cause damage to the intestinal epithelium. So chronic ethanol injection can cause damage to intestinal epithelium. That itself can cause diarrhea because of the malabsorption. They can cause diarrhea. So any patient, chronic alcoholics also can have diarrhea. Any drugs and toxins or any bile acids, as I told you, and also bowel reception can cause because of the malabsorption. They can cause any, like these carcinoid, VIPomas, medullary carcinoma of thyroid. I mentioned all about this. These are very common. They're not very common actually. Sorry. And carcinoids, VIPomas, medullary carcinoma of thyroid, mastocyte because of the histamine, and gastrinomas because of the increased acid secretion. And these are all can cause diarrhea. There are tumors that can cause diarrhea, but they're very uncommon. That's why I didn't mention about in the case report. Carcinoid because of the increased serotonin, and mastocyte because of the histamine release, and gastrinoma because of the increase in the acid production. So these are all possibility. And electrolyte absorption defects also is a possibility. Osmotic, in the case of any magnesium phosphatic containing laxatives, is a possibility. Any lactase deficiency that can cause malabsorption of lactose, and any disaccharide deficiency also can cause, because of the malabsorption they pull the water into the intestine, that can cause osmotic causes. Any non-absorbable colic like sorbitol, lactulose, you give any PEG, if you give any of them, they can also cause osmotic diarrhea. Any gluten and FODMAP, as I told you, gluten and FODMAP intolerance can also cause osmotic diarrhea. Steatorrhea, any pancreatic exocrine insufficiency or bacterial overgrowth can cause. Bariatric surgery can cause. Liver disease, because liver produces bile acids. So bile acids are required for the micelle formation. So that can cause diarrhea. And mucosal absorption in the case of celiac, peoples we discussed, beta lipoproteinemia we discussed. So ischemia can cause. Post mucosal, like any lymphatic obstruction. So it sometimes intestinal congenital lymphatic obstruction can be possibility, and lymphangiectasia is a possibility. They can also cause. They are very rare, but they are also a possibility. Any inflammatory disease like Crohn's disease, ulcerative colitis, or lymphocytic and collagenous colitis, like I discussed in the especially SSRIs and PPIs and statins and NSAIDs. And any immunodeficiency. Sometimes the patient having common variable recurrent infections or recurrent chronic diarrhea is a possibility. Especially some patients who is having recurrent acute GE, sometimes you look for immunoglobulins also, because they will have a low common variable immunization where they have low immunoglobulins. So that is also a possibility. So some patient who is recurrently admitted with acute GE, always look for CVID, common variable immunodeficiency, or IgA deficiency is also a possibility. Look for immunoglobulin panel also. Sometimes recurrently admitted into the ward, like more than usually if they are getting with acute GI, you look for immunoglobulins also. Any infections are a possibility. Like especially who are on the long-term antibiotics, you always look for Clostridium difficile. Any colonoscopy you do, pseudomembrane is there, Clostridium difficile is a possibility. Irradiation can cause, malignancies can cause. and also irritable bowel syndrome will cause, visceral incest, hyperthyroidism can cause diarrhea, and any drugs, prokinetics can cause post-vicative. Munchausen's is mostly factitious, like they can cause factitious diarrhea. Cholecystectomy we discussed, ileal resection we discussed, bariatric surgery, vacuotomy. These are all the various causes of chronic diarrhea. So this is how you look for. So any chronic diarrhea, exclude any iatrogenic cause or any medication or recent surgery you should look for. Then any bleeding per rectum is there. Always go for colonoscopy and biopsy. Look for any malignancy or ulcerative colitis is a possibility. Any fatty diarrhea, always look for small intestinal bowel imaging. Always any stator is any more than 7 grams is generally per day is considered as steatorrhea. So any fatty diarrhea is there. Classically they are mentioning greasy stools. Always look for small bowel imaging, and biopsy or aspirate should be done. For any bacterial overgrowth is there, any duodenal like celiac is there, Whipple's is there, any pancreatic imaging also needs to be done. And like this is a classical pain aggravated before bowel movement and relieved after bowel movement, and sense incomplete ejaculation, you should always suspect irritable bowel syndrome. But before labeling any functional disorder, you should look for the anatomical look out for any anatomical cause, like you look for ESR, iron deficiency, folate deficiency, B12, TTG, and C4, any stool for excess fat, calprotectin for any inflammatory bowel disease. You need to look for all of these causes to rule out any just to rule out any anatomical, any celiac is possibility, any inflammatory bowel disease for looking for inflammatory markers, calprotectin, CRP, ESR, and C4, and TTG for celiac disease, B12 and folate. Any nutrition malabsorption is there. If malabsorption is there, you look for celiac disease, you look for Whipple's disease, you look for biopsy from the small intestine, you look for the culture from the biopsy, small intestine, look for any small intestinal bacterial overgrowth is there. You need to evaluate based on that. So if the patient has low biopsy, low MCH, you look for the colonoscopy and biopsy, and small intestine biopsy is there. Also look for stool for fat. If more than 20 grams per day stool fat is there, it is generally suggested of pancreatic dysfunction. If 14 to 20 is there, generally it's a small bowel cause. It is due to the malabsorption or due to the small intestinal bacterial overgrowth. That is a second possibility. If generally less than 40 grams is there, what happens is there that generally sometimes like slow transit there is something called rapid transit time. So some people have like sometimes the fat you won't give, like because of the rapid transit, it won't give enough time for the fat to be absorbed in the intestine. So sometimes they'll have fatty diarrhea. So that is a possibility. Generally they'll have fat around 7 to 14 grams only. So that is normal due to the rapid transit time. Sometimes they'll have. So generally 14 to 20 is suggest a small intestinal cause. More than 20 is suggest a pancreatic function. So if the low serum potassium is there, always look for hormone endocrine causes mainly. VI POMA is there, any gastronoma is there, always look for that. And also stool osmolality should be done. If all of these screening tests are normal, so you label it as loperamide, you label it as IBS or something. For IBSD, you should generally advise loperamide is the first drug you advise, opioid treatment, that is loperamide you give. So persistent chronic diarrhea is there after that, you do full gut transit time. So that is also a possibility that is mentioned. Normal stool fat also, rapid transit time also can have like steatorrhea because it doesn't have enough time for the intestine to absorb. So if persistent chronic diarrhea is there after loperamide therapy also, you always do full gut transit time. So and also give bile acid, 48-hour bile acid to look for any bile acid diarrhea. That is also possible. So this is how you work for the chronic diarrhea. So any weight loss, anorexia, this is a mechanism. Diarrhea, increased malabsorption, flattens bacteria. For flatus is due to the bacterial fermentation of unabsorbed carbohydrate. So glossitis, these are the presenting manifestations for a vitamin A, B12 deficiency, where glossitis, cheilitis, stomatitis is a possibility. Any abdominal pain due to inflammation of pancreatitis. Bony pain suggests of any so if the patient is telling bony pain, you should suspect calcium, vitamin D absorption or protein deficiency. Tetany is there, again calcium and protein malabsorption. Weakness can be due to anemia. So amenorrhea is due to the protein depletion, decreased calories or secondary hypopituitarism. Anemia, bleeding is due to the vitamin K malabsorption. So these are the symptoms you need to ask for any deficiencies. What are the symptoms? Peripheral neuropathy, B12 deficiency and thiamine deficiency. Dermatitis can be due to vitamin A, zinc deficiency. So these are the symptomatology patient will tell. So that is suggest a certain deficiencies. That is how you look at it. So this is the urine dextrose test. So you give 25 grams of dextrose and collecting urine for 5 hours. So any abnormal test is suggest of less than 4.5 grams is suggest of malabsorption. So carbohydrate malabsorption. You give 25 grams of dextrose. So after you collect for 5 hours. If less than 4.5 grams is there, of dextrose is there, it is suggest duodenal jejunal mucosal disease. So that is suggest a malabsorption disease. So abnormal test can be present in the case of delayed gastric emptying or impaired renal function. So this test is abnormal. So you need to rule out any delayed gastric emptying is there, abnormal renal function is there. So in that case, this test is not much useful. So other causes of malabsorption, it can be due to inadequate digestion, that can be post-gastrectomy or any pancreatic enzyme deficiency or reduced bile acid concentration, that might be due to liver disease or bacterial overgrowth can cause, and also in intestinal resection is there, Crohn's disease is a possibility. Impaired mucosal absorption can be due to the any intestinal resection or bypass, inflammation due to Crohn's or amyloidosis, scleroderma, they can cause intestinal mucosal damage. People, celiac, collagenous sprue, folate, B12 deficiency. Folate deficiency in the case of tropical sprue, what happens is folate supplementation also you need to get in the case of tropical sprue, because folate itself can help repair in the intestinal epithelium. So folate deficiency can cause intestinal damage. So that is also a possibility. Genetic disorders like beta lipoprotein disaccharides are a possibility where impaired absorption, malabsorption is there. So intestinal nutrition delivery to the intestine, that is the lymphatic obstruction or lymphangiectasia as a possibility. Any circulatory, even congestive heart failure also, constrictive pericarditis also, you generally don't give oral iron because there is some amount of malabsorption because of the defect in the transport from the intestine to the blood. So because of the excessive congestion, there is defective transport. That's why in congestive heart failure, if you want to give oral iron, you give in the IV iron only. So that is the reason that can cause malabsorption. That is also congestive heart failure. Constrictive pericarditis is also a possibility for malabsorption. That is also unique. Like any endocrine, diabetes, hypoparathyroidism, adrenal insufficiency, hyperthyroidism, carcinoid, these are also can cause malabsorption. So these are the various causes. That is one. One more cause is diabetic diarrhea. So diabetic, because of the atomic dysfunction, also can cause diarrhea. That is a diabetic diarrhea. That is also a possibility. But this one thing, congestive heart failure can cause malabsorption. This is one more thing you need to remember. So this is how pancreas will help in lipolysis. Liver produce bile acid that can form micelle formation. So they're esterified and absorbed into the jejunal mucosa and they're delivered to lymphatics. These are all important in the absorption of fats. So even pancreas damage is there, CLD is there, any jejunal mucosal damage is there, that can be due to celiac or Whipple's or tropical sprue, SIBO, anything is a possibility. That can cause lipid malabsorption. Lymphatic problem also can cause lipid malabsorption. So these are the various lipid, long chain fatty acids. They are generally triglycerides. They require primary site is small intestine. They require pancreatic lipolysis and micelle formation. So these are the medium chain fatty acids. They are also absorbed in small intestine only. They are 8 to 12 carbohydrate. So they don't require pancreatic lipolysis or micelle formation. That's why in any malabsorption, in pancreatic insufficiency or any malabsorption, you generally, or any bile acid disorders or something, you generally prefer medium chain fatty acids. This is the reason. So generally they don't require any pancreatic enzyme or micelle formation for the absorption. This is why. Generally short chain fatty acids are generally formed from the fermentation of carbohydrates in the colon. They are generally not present in the diet. They don't get generally absorbed also much. So generally found in the colon. So the enterohepatic circulation. So this is the reason. Generally bile acids are synthesized in the liver. That's why any cirrhosis can cause bile acid that is required for the micelle formation and lipid malabsorption. Bile secretion that can be due to primary biliary cirrhosis. If that is problem also, that can cause lipid malabsorption. Maintenance of conjugated. So this bacterial SIBO, whatever is causing, no? So conjugated bile acids are required for the micelle formation. If they are unconjugated by bacterial overgrowth, so micelle formation won't occur. That can also cause lipid malabsorption, like lipid malabsorption. Any reabsorption like Crohn's disease can cause abnormal ileal function, that can cause malabsorption. So these are all any synthetic defect, any transport defect, any like conjugation of bile acid, they all can cause bile acid dysfunction that can cause lipid malabsorption. So this is the different. This is the treatment of IBS. First, you will advise low FODMAP diet. So what are the low FODMAP diets? I will advise later. So increase in soluble fiber, especially for IBSD. Physical activities. Avoid stress and sleep deprivation. This is one more thing. So next, for IBSC, you advise osmotic laxatives or antispasmodic. You can go lincolnlatide, lubiprostone, tenofovir, sodium hydrogen exchange 3 inhibitors. You can give that. You can give SSRIs for pain mainly. For mixed, you give both combined. For IBSD, mainly you give antispasmodics and loperamide, which is opioid class of drug. You can give rifaximin also. You can give cholestyramine for bile acid sequestration. You can try ondansetron, which is also anti-motility drug. And TCS are used in the case of pain in the case of IBSD. For SSRIs are used, SSC as the one, both sound similar. SSRIs are used in the case of pain for IBSC, whereas you use for tricyclic antidepressants for pain in the case of IBSD. So these are the various drugs you can use. Mainly you give, in IBSC you mostly give laxatives with antispasmodics. In IBSD you give loperamide with antispasmodics. Later on, based on the management, you can titrate upwards. First you address physical activity and avoid stress and sleep deprivation and low FODMAP diets. These are the various FODMAP diets. You need to avoid fruits, mainly fructose containing fruits, mainly apple, mango and watermelon all, and sweeteners like high fructose, maple syrup or fructose containing fruit. Any fructose containing, any lactose containing foods also needs to be avoided, like milk or yogurt or cheese or something. Broccoli also, sometimes broccoli also, after eating broccoli also they sometimes complain diarrhea. So these are all eggplant, these are all needs to be avoided. Any cabbage are also needs to be avoided. So any legumes, beans also, sometimes beans are also contain FODMAPs. So any kidney beans, and especially beans contain all polyols. So you remember this list and avoid these foods. You can eat these foods. So this is the foods. These foods can also cause diarrhea, so you need to avoid them. Thank you.